Patient number 12 is a 65-year-old former Democrat member of the Alabama State House of Representatives who represented her home district for 26 years. She has developed advanced hepatitis with cirrhosis of the liver. She requests a Priority 1 liver transplant. As a former Democrat Party member and chairman of fundraising for her district, she also qualifies for whatever care we can give her, and the cost here is no object. I vote to approve any and all treatments, including liver transplant, for this fine woman.
I vote yes, as she was one of my role models when she served as a high-ranking member of the Alabama Democratic Party Fundraising Committee, and she's a tireless advocate for women's rights.
I also vote yes. Cost should not enter into our decision for this person. We can just disallow some of the other treatments for other patients and recover the cost there. She helped push our healthcare reform legislation and kept the Republicans from defeating our agenda.
Unanimous yes, she's approved. Now, patient number 13 is a 70-year-old male with an inoperable brain tumor. His doctors want to get brain surgery or craniotomy approval so that they can inject an experimental anti-cancer compound directly into the tumor, which is located near the base of the brain. The procedure is costly and the benefits from the treatment are doubtful at best. I vote no and recommend he be referred to hospice for palliative care and end-of-life counseling. His past history of smoking, heavy alcohol consumption, and previous marijuana use is against any other treatment for him. I vote no.
He only has an estimated lifespan of another 3 years even if we do treat him. I vote no.
I also vote no. Denying him treatment like this is costly and just makes sense to me. He can be made comfortable, and like some of the others we covered today, I would agree that he'd be a candidate for hospice or even assisted suicide.
Okay, rejected. Now, the next patient, patient number 14. The next patient has crippling rheumatoid arthritis. She is 30 years old and has been under treatment for this condition since her early 20s. Her rheumatologist wants to try a new immunosuppressant drug, but admits it is 4 times more expensive than what he has used before. She is a CPA and makes an excellent living and has an estimated lifespan of 40 more years. Without the drug requested, she will still live as long, but won't be able to work and pay taxes. I recommend that we approve her treatment at least for 1 course of therapy.
Yeah, I agree. I think we should at least prove 1 more round of treatment. It does sound cost effective to me, so I certainly vote yes.
I vote yes. I notice in her bio that she's a county chairman for the Democratic Party and is quite active in fundraising for our candidates. She deserves our help and intervention.
Fine, I'll stamp her approved then. Patient number 15 is a 40-year-old female who is at least 100 pounds overweight. She was referred to this committee as an emergency, is diabetic, and is in and out of the hospital with congestive heart failure. She was admitted 2 weeks ago and discharged after 10 days. She's back home now, but is back in failure and wants to be readmitted. We don't usually cover a second admission if it isn't at least 30 days since the first. She was seen in the hospital emergency room last night, and her doctor wants us to approve her hospital stay as an emergency. The doctor kept her in the ER and has given her emergency outpatient treatment, and she is somewhat improved, but he feels she would benefit more if she spends a few days in the hospital. What are your thoughts?
This is a classic case of the patient and the doctor gaming the system. It's not our fault that she ate too much and caused her own problems by gaining this massive amount of weight. Why should we subsidize gluttony? I vote no and think she should go home, get on a diet, and be treated in her doctor's office.
I also vote no. She probably brought her problems on by herself by overeating and sitting around her house. Her doctor needs to read her the riot act about dieting. She has an estimated additional lifespan of 4 to 5 years more. It doesn't seem cost effective to keep putting someone like this in the hospital over and over again.
I vote no. I can have one of my assistants call the ER and tell them we will approve their outpatient therapy but will not pay for any hospital admission. So she is rejected. The last patient is a 58-year-old female who is diabetic, hypertensive, and overweight by at least 50 pounds. She has had problems with kidney function for the past year and is non-compliant in her doctor's efforts to follow her diet and take her blood pressure medicine properly. Her sugar and sodium intake are excessive, and her prognosis is grave if she doesn't get kidney dialysis started. What are your thoughts on this patient?
This woman has done nothing to help her doctor prevent this problem. She is not compliant with any reliability in following her doctor's orders. Even if she were doing as she was told, she's over 55, and that's an automatic rejection if we go by the guidelines FCCCER sets. I vote no, since she doesn't seem to deserve any heroic treatment.
I vote no for the same reasons.
I vote no as well. Well, the meeting is now over. For the record, let me thank the other two members of the committee for their service. All 16 subjects discussed will be notified immediately by the state office of FCCCER of our decision. This is the way our healthcare system could be, but it doesn't have to be this way. If enough people are angry enough to fight this unreasonable rationing of care by government bureaucrats, then we might prevent committees from deciding what your health care will and won't include, and whether or not you live or die based on economics. Time is short, so let your congressmen and senators know how you feel.